everyone. Thank you so much for joining us today. My name is Saru Kaiser, and I am the Program Manager here at Breast Cancer Action. Joining me on the webinar today will be Galen Joseph, Associate Professor in the Department of Anthropology, History, and Social Medicine, and the Helen Diller Family Comprehensive Cancer Center at the University of California in San Francisco. And we also have Cindy Pearson, Executive Director of the National Women's Health Network. A few quick announcements before we get started. Breast Cancer Action doesn't take money from any corporation that profits from or contributes to the breast cancer epidemic. Our work is largely supported by individual donors. Please consider making a $25 donation today to support work like these educational webinars. Our presentation of the trials of clinical trials will last about 45 minutes. At any time during the webinar, you can ask a question by typing it into the question bar, and we'll save time at the end to answer all your questions. We want you to get involved with Breast Cancer Action, and this webinar is a great way to do that. And we'll talk about some other ways later on in the presentation. I'm going to take a moment to go over our agenda. We're going to start with Galen, who will talk about the importance of ensuring adequate representation in clinical trials. She'll also talk about what some of the barriers are to doing that. And she'll talk about some successful strategies that are being used to address some of these barriers. And then Cindy will come on, and she will talk about the FDA's role in ensuring diversity and what the FDA action plan is. And again, we'll end with time for as many questions as we can. Now, Breast Cancer Action was founded in 1990 by a group of women living with breast cancer who realized the power of community. They founded Breast Cancer Action because they saw a need for a grassroots organization with a unique understanding of the political, economic, and social context of breast cancer. Our founders, only one of whom is still alive today, knew that their private medical crises were part of a larger public health emergency, and that the experiences of those dealing with breast cancer needed to be heard to address the crises. We are the only organization that addresses the breast cancer epidemic at the intersection of breast cancer, the environment, social justice, and feminism. And our mission is to achieve health justice for all women at risk of and living with breast cancer. I want to take a moment just to talk about our core values and really grounds how we do the work that we do. We believe in health justice as a human right, honesty, fearlessness, and truth-telling about the breast cancer epidemic. We believe in honoring women's diverse voices and lived experiences, people's health and well-being over corporate profits, transparency and accountability for ourselves and others, collective action that changes the world for the better, and last, we believe in integrity and freedom from conflict of interest. Now, we recognize that the issues of health and social justice are really intertwined through the work that we do. And as you heard, they really inform our core values around ending the breast cancer epidemic. Our commitment to social justice is a real foundation in all the work that we do. And I want to talk a little bit about the pieces of that commitment. So, there is an unequal burden of disease, and we know that the breast cancer epidemic impacts communities unequally, and it leads to unacceptable differences in who develops breast cancer and when it develops, who gets high quality and timely treatment, and who dies from breast cancer. We also examine the root causes of this disease because in order to address and end the breast cancer epidemic, we must tackle the root causes of these health inequities, which are often a result of a complex interplay of culture, power, economics, racism, and sexism. We also believe that no single injustice can be effectively addressed in isolation, and we recognize that injustices in our society really reinforce each other in many different ways and at many different levels. And last but not least, in our work for health justice, we strive to be an ally by using the power and privilege we hold as an organization to build solidarity with communities who currently and or traditionally have had less access to power, information, and resources. Now that's a bit about how we do our work. Now what's the actual work that we do? And as a watchdog for the breast cancer movement, we educate, organize, and take action for systemic change in 3 different areas. And the first is breast cancer screening, diagnosis, and treatment. Our work in this area examines the data from a patient perspective and includes topics such as breast cancer screening, healthcare access, drug and device approval, as well as demanding more effective, less costly, and less toxic treatments. The second area is around the root causes of breast cancer, and this is where our work is really focusing on eliminating the involuntary exposures to hazardous and toxic chemicals present in all our daily lives that puts us at risk for an increased risk of breast cancer. And the last area is around pink ribbon marketing and culture. And this is where our work to end the breast cancer epidemic cuts through the pink noise to tell the hard truths about this disease and challenge pink washing hypocrisy and the pink ribbon culture that has become the status quo of the breast cancer industry. So that is a little bit about Breast Cancer Action, and I want to take some time to talk a little bit about our presenters, and then I will turn it over to them. Our first presenter is Dr. Galen Joseph. She's an associate professor in the Department of Anthropology, History, and Social Medicine at the University of California, San Francisco, where she's also a member of the Helen Diller Family Comprehensive Cancer Center. Her research at the intersection of medical anthropology and public health investigates the socio-cultural and institutional dimensions of inequities in healthcare by using mixed methods and community-based participatory research. Galen is a co-editor of the book Breast Cancer Gene Research and Medical Practices, Transnational Perspectives in the Time of BRCA, and has published numerous articles in social science and medical journals. Welcome, Galen. Our next presenter is Cindy Pearson. She's the Executive Director of the National Women's Health Network. Founded in 1975, the network was the first feminist health group to utilize a national membership in support of DC-based health activism. The network's goal is to bring the voices of women everywhere decisions are being made that affect women's health. Cindy became the Executive Director in 1996. Having been a part of the network team since 1987, she's coordinated the internship program, managed the Information Clearinghouse, and directed the National Women's Health Network's program and policy work. In addition to representing the network in the media and to the government, Cindy has served on the boards of the Reproductive Health Technologies Project, the National Action Plan on Breast Cancer, the Campaign for Women's Health, the DC Women's Council on AIDS, and the advisory board of Our Bodies Ourselves. Cindy is a transplanted Californian who moved to Maryland after obtaining an undergraduate degree in biology from UC San Diego. Welcome, Cindy. Now I'm going to turn it over to Galen.
Thank you very much, Saru. I'm delighted to be here with all of you today, and today I'm going to talk about cancer clinical trials, inequities in participation opportunities. So briefly, I'm going to be discussing why inclusion in research matters, barriers to participation, and successful strategies to reduce barriers. Sorry, I'm just getting used to the slides advancing. So I want to begin by just briefly reviewing who actually participates in cancer clinical trials. Despite the 1993 National Institutes of Health mandate to include women and minorities in clinical research, recruitment of minority participation of participants remains a substantial challenge. Fewer than 10% of adult cancer patients participate in clinical trials, and participation rates for people of color are even lower. So why does this matter? Before we talk about why participation is so low, I just want to talk briefly about why inclusion in research matters so much. So first, recruitment to and retention in research is necessary to ensure the generalizability of study findings. We don't actually know that everyone will respond in the same ways to all treatments, need the same doses of medications, etc. If the population included in research represents the population at large, we have the opportunity to find out. Second, inclusion matters because it ensures the fit and adequacy of treatments and interventions for various subgroups. Otherwise, critical life-saving treatments and quality of life interventions and services developed and validated through research may not address the needs of women of color and other underserved populations. And third, it is a matter of justice and fairness. Federal money is being used to pay for many of these trials, and in some instances, the trials provide treatment options not otherwise available. So there are many reasons why so few people participate in cancer clinical trials. There are barriers really at every level of the clinical trials apparatus, at the systems level, the institutional level, the provider and patient levels. And I'll walk us through each of these in turn. So in terms of systems barriers, while individual patients are recruited to particular trials by individual providers, recruitment processes are shaped by structural inequities in the U.S. healthcare system that create differential access to medical facilities that have different and unequal research infrastructures. Different kinds of trials and the clinical context in which cancer patients are invited to participate may accord different benefits and burdens to patients who choose to participate, as well as to the providers who recruit them. So there are systems barriers that require specific eligibility criteria to be met. Often these are very narrow. There are often very complex consent forms, sometimes very long, sometimes truly incomprehensible. And usually the people administering consent are English-speaking staff, and the consent forms are rarely translated into other languages, despite the fact that large percentages of the population in many parts of the country speak English only as a second language, if at all. In some cases, there are costs associated with participation, and of course, not all trials are located in all locations. So when we think about institutional barriers, I'm thinking about barriers that exist at the level of the institution that's hosting a particular clinical trial or trials. And important questions to think about in this regard include what is the institutional mission? The institutional culture and the incentive structure regarding patient care, research, medical education may have an influence on to what degree resources are allotted to research and the degree to which the staff in any given organization is really invested in carrying out research. So what is the institutional support for opening trials and other kinds of research studies? In many cases, an individual champion is really needed to make sure that trials can open in lower resource settings. And in general, the organization's size and staffing and how the degree to which they have an infrastructure for research is a major issue. There are also barriers and a range of issues that prevent providers from recruiting diverse participants. In a study that I conducted with my colleague Daniel Doan a few years back regarding how patients are recruited to clinical trials, where we compared an academic medical center to a public hospital, we found that providers in the academic medical center were really trying to seek out patients they considered good for studies or good study patients. Those were patients they believed were easy to communicate with about complex issues, those they thought they could rely on to complete the trials. And this introduces the potential to exclude people they deemed harder to communicate with, or people who maybe were just less like themselves, people with less education, lower literacy levels, people who perhaps didn't speak English. In addition, when thinking about things that may prevent providers from recruiting diverse participants, we have to think about and remember what the incentives are for the providers who are doing the recruitment. If the trial is investigator-initiated, that is, if the provider is actually a researcher, him or herself, and initiated the trial, that provider is going to be very motivated to recruit people so that he or she can complete the research and publish it, and also may be very invested in improving the patient's lives, and that may be why he or she is involved in research to begin with. There's also a whole set of studies that are funded and supported by the National Institutes of Health, National Cancer Institute, through a set of cooperative groups. And those are available for medical centers and hospitals to open up around the country. So there may be somewhat different incentives when an institution signs on to a cooperative group trial. And then, of course, there are pharmaceutical-sponsored trials, which also have different incentives. In that case, there may be a financial incentive. So there are also barriers that can impact whether patients choose to participate in clinical research. There is a long-standing belief in particular that African Americans are less willing to participate in research due to the legacy of the Tuskegee study. And more recent research has shown that that is actually not true, and that African Americans and other U.S. racial and ethnic minorities are not less willing to participate in research. And as a result, that it makes more sense to increase minority participation in health research by focusing on ensuring access to health research for all groups rather than changing minority attitudes. Nevertheless, there are some barriers from the patient perspective where some patients may be reluctant to participate if they have misconceptions about research, and that may be unrelated specifically to Tuskegee and the history of exploitation in some research studies historically. It may have to do with other kinds of misconceptions about research. It may have to do with just having lower health literacy, and so having more difficulty understanding a physician's explanation of a trial. There may be distrust of researchers or of doctors. There may be difficulty getting to appointments due to transportation or difficulty with the cost of health care and insurance. Excuse me. Despite the fact that in 35 U.S. states and territories, policies have been implemented requiring insurers to cover patient care costs in the context of cancer clinical trials. A recent study showed that these mandates did not appear to confer a benefit in terms of accrual to, in particular, they looked at the NCI clinical trial cooperative group studies. So in these states, this requirement that any costs associated with participating in a research trial didn't actually seem to lead to greater participation. So I want to move on now to talk about some of the successful strategies that have been tried and identified in a range of studies. And these address both interpersonal issues, institutional and systems change and challenges, and the community and social context. And some successful recruitment and retention strategies have been culturally informed and population specific, yet interventions that address patient-level barriers such as mistrust of medical staff and the research community can only be effective if systems barriers such as strict eligibility requirements, the linguistic complexity of consent forms are addressed, and the opportunities to participate are actually viable for low socioeconomic status individuals and limited English-speaking patients. So one of the successful strategies was instituted by the National Cancer Institute as part of the NCI's Community Oncology Research Program, or NCORP. And this was originally created under a different name, the NCI's Community Clinical Oncology Program, in the 1990s. And basically, these centers, these sites, as you can see on the map here, are funded in an effort to distribute clinical trials funded by the NCI around the country to all of these different sites. And the NCI, or rather the NCORP, is it's a national network of investigators, cancer care providers, academic institutions, and other organizations that conduct multi-site cancer clinical trials and studies. And they have specific sites that they have identified and included where the populations in the community-based healthcare systems are diverse, and so have at least 30% minority patients. So the overall goal is to bring these cancer clinical trials to individuals in their own communities, thus generating a broadly applicable evidence base that contributes to improved patient outcomes and a reduction in cancer disparities. And over the years, these minority sites, as they're called, have been shown to accrue a much higher rate of minority participants, which is pretty a logical outcome. But it's clear that if you give the appropriate resources to communities that have large minority populations, you can actually recruit them to participate. And then the last successful strategy I want to just talk about briefly addresses both institutional and patient barriers to participation. And this is a collaboration among UCSF researchers, myself included, a community-based organization called Shanti Project, which provides patient care navigation to underserved breast cancer patients and survivors, and breastcancertrials.org, a web-based clinical trials matching service. And the goal of our project is to reduce disparities in health research information and access to participation by building capacity among key players in the breast care system in the San Francisco Bay Area, so building capacity of both Shanti and breast cancer trials to address these issues of information access and access to participation, and then implement a navigator intervention with post-treatment breast cancer survivors and metastatic patients with stable disease to inform them about health research in general and how to find opportunities to participate in breast cancer research. So our hypothesis is that a trusted community-based organization via a navigator-delivered health research intervention can improve knowledge about and positive orientation towards participation in health research, can increase engagement in health research information seeking, so attempting to obtain information from the Breast Cancer Trials website or helpline, and to improve perceived efficacy to obtain health research information. So we want the clients of Shanti to feel empowered to find information about health research if they're interested in it. So our underlying idea and guiding principle is that research must be familiar, available, accessible, and credible. So I just want to thank my collaborators at Shanti and breastcancertrials.org, and of course, Breast Cancer Action. Thank you.
Hi, everybody. This is Cindy Pearson, and Charu and Galen and I have sort of thought through what's the flow that makes the most sense. And to us, it makes sense for Galen to have gone first and talked about some of the social context for the difficulty in participating in clinical trials. And now I'm going to talk about, is there, so that's sort of the input side, and I'm going to talk about using the not the output, but the a checkpoint in the process to try to not only get more information, but get access to the information that exists. So I'm learning how to advance my slides, and I don't see it working, so I'm going to say next. Thanks. So the big question, you're now being encouraged to take a drug. It's been prescribed for you, and the question that people who are in a partnership style with their providers or in a skeptic style of relating to health information is, will this work for me? And historically, 20 years ago and further older than that, it was pretty clear that, and there were glaring examples of how women weren't included in clinical trials in sufficient numbers. And there are reasons why that we've touched on already through Galen's presentation. There were some reasons that activists thought were amenable through advocacy targeting the National Institutes of Health, and then also advocacy targeting the Food and Drug Administration, because if the Food and Drug Administration is ultimately responsible for reviewing the data and assessing that there's a good balance of risk and benefit, what does the Food and Drug Administration know about how many women were in clinical trials when they made that assessment? The FDA looks at this information, but it does not hasn't had the resources to keep systemic records of how many women are in clinical trials. And so the information that's available from the FDA is episodic. It's a snapshot at a particular time. And so that leaves us still not fully informed, and also having examples of missing information, gaps in information, where either women or people older than age 65 or people of color are not included. So for example, lung cancer trials often do not have enough women and people of color to be analyzed separately. Alzheimer's disease is a condition that is diagnosed more often in women than in men, but those trials are not designed typically to look at gender differences. And similarly, heart disease, which affects women as often as men, is in many of the big trials, there have been fewer than 50 and fewer even than 40% women. And so I know this is an audience that cares a lot about breast cancer. So next slide, please. What do we know about breast cancer drugs? Well, if you look at the label, that long, detailed, super wordy listing of information that comes with it, you won't find that answer. You won't find how many women of color, how many women over age 65 were involved in the large pivotal clinical trials. And what about if you're a bit more of a consumer researcher and you decide to get online and see if you can find out yourself? So not that our network interns are as savvy a consumer researcher as someone who's educated themselves in breast cancer, but just as a little exercise, we asked one of our very smart interns to research online what she could find out. And doing basic keyword searches, she was only able to find one trial that in a keyword search spoke to diversity of the women enrolled, and it was a trial of side effects of aromatase inhibitor. It was a trial of interventions to reduce one of the side effects of aromatase inhibitors. Now, I am the first to say there is more information than that available, but not in an easy-to-use, easy-to-find format. And what about why is it, if a drug is tested specifically in women, why is it important to know about older women and women of color? Well, in both cases, justice, fairness, these women are going to use the product. And in the case of older people, there's good, solid evidence that metabolism is different as you age. In the case of women of color, women from different racial and ethnic backgrounds, there is not good evidence that the biology of our bodies is different. In fact, the philosophers of science say that race is not a scientific category. It's a social category. So when I bring up, and when Galen has brought up diversity of enrollment and finding information on diverse people who've been part of trials, we want that as a justice issue. But okay, now what about when it's women versus men? Is there a biological difference? Well, yes, obviously there's a biological difference in our reproductive capacity. And we do have some evidence that at least in some cases, some but not all, drugs affect women differently than men. And we just don't have a really good idea of how many. So here's a couple of examples where the risk, these were serious risks. These drugs are now have been withdrawn, but at the time that the risks were realized, it was realized that the risks were greater for women. So that makes us think that where there's smoke, there's fire. If we've seen some examples of drugs affecting women differently, it would be really good to know how more about all the drugs. So the next slide, please. So this slide is to show you what the world looks like if your only tool is a hammer. The world looks like a lot of nails. All your problems look like nails. Now, we know all the problems about getting good information about older people, women, and women of color are not all nails. Not all the problems are the same. But the FDA is our hammer because the FDA is a consumer protection agency and they are accountable to consumers, and we can try to address the problem and have tried to address the problem of not enough information about women in clinical trials through the FDA hammer. And on the next slide, you see that no tool works until you use it. And so this is a picture of a woman getting ready to swing the hammer. And this woman is our our illustration of Congress, because Congress has a really strong arm to swing the FDA hammer. The FDA is very open to hearing from consumers and patients, but sometimes it takes more than our voice to move them as much as we believe they should move. However, Congress approves FDA's budget every year, and it's funded, the FDA's budget is funded in part by the fees that drug, device, and biologics manufacturers pay to have their applications reviewed, and Congress has to reauthorize those fees every 5 years. So the most recent reauthorization was our opportunity to swing that FDA hammer, and the National Women's Health Network and our allies, Women Heart, American Heart Association, and the Society for Women's Health Research collaborated on an advocacy effort to tell the FDA to do some of these things that we wanted. So on the next slide, you'll see what Congress advocacy looks like. It looks like wordy, wordy, wordy. This is actual words from a bill that became a law and is now statute. And I've picked out the key words there in red. It's an action plan. So in 2012, this law went into effect. It directs the FDA to act to swing that hammer. And we owe particular thanks to Congress women Debbie Stabenow and Lois Capps for being our champions on this. And through their work and resulting in this language, the FDA was directed to first report on what could be known about women, people of color, and older people. That's the phrase demographic subgroups towards the top of that slide. To report on it, but then to also issue an action plan. And yay, FDA, they issued the action plan in August of 2014, and on the next slide you see the three main ways that the FDA wants to address, as in their words, enhance the collection and availability of demographic subgroup data. So in our words, that means to encourage trials to be done that include more women and to make that information available. So on the next slide, you see one of the things they've done that is really cool. This is an FDA drug snapshot, and this is a first time ever easy to use information sheet that tells you more than what you get if you look at the nitty-gritty, long, super detailed label. And this is a screen grab from the FDA's website. You see the URL below. The drugs are listed to the left, and they're listed for each reason they were approved, so sometimes you see a drug listed twice. And this drug, which was approved February 23rd of this year for a cancer treatment, on the next slide, I'll show you the snapshot, part of the snapshot of the drug. There's more words, and all credit to the FDA. These words are written in an easy-to-understand fashion, and they use infographics because they know people understand information visually as well as words. So here you see a nice little pie chart, and look at that, 46% women and 54% men in this trial of a multiple myeloma drug. And that's pretty good because that's about how that's not far off how the incidence of the disease plays out. But look over on the other part where you see the bar graph, and 65% of the participants white, 30% Asian, and only 3% black or African American. That is really discrepant from the way the disease plays out. As it turns out, this type of cancer, while pretty rare, is actually more common in African Americans than in whites, or more commonly diagnosed in African Americans than in whites. So right there on our justice issue, we see, wow, this company wasn't able to do a good job of making their trial manageable for the representative patients who get the disease to participate. So the drug snapshots are serving their purpose in a really good way. They make this information easily available. And the FDA has heard our criticisms of this before, so I'm not saying they haven't heard anything before, but we kind of want the drug snapshots to be more like the Zappos shoe site. So when I'm on the Zappos shoe site, I can put female, i.e. I can put my shoe size, I can put my ethnicity, i.e. my shoe color, and I can zoom in on how many shoes in my size and my color. But on the FDA website, it's static data, or on these drug snapshots. I can't click on female and then click on my ethnicity and zoom in and see how many of me there were. And I have to say that so far, this is just about 13 drugs, I think, that none of these drugs has enough people of color, and in some cases not enough women to be analyzed separately. So it's the other thing we don't like, and we really wish, is that the FDA had the resources to go back in time, because they're only putting these drug snapshots up for drugs that have been approved since January 1st, 2015. But on the next slide, you see a couple of other good things the FDA is doing. So in addition to us being able to see how many people like me were in the trials of this drug the FDA approved, what else can the FDA do to influence the likelihood that they'll get submissions with a good number of older people, people of color, and women? Well, they can put it into the reviewer's template for the reviewer's assessment of the application, and that's they've committed to doing that, not putting it in the template and training their reviewers about how to use that revised template. And the other thing they've committed to do in 2016 is to have a public meeting about this issue. And the good thing about a public meeting is the companies will need to come, and it'll give us advocates a chance to hear from the companies about what they're doing to do better, and if not, why not. So on the next slide, I want to make the point that the clock is ticking. So this is a picture of President Obama being inaugurated. And on January 20th, 2017, we are going to have a new president. And as an advocate with that you heard my long time working in advocacy, some FDA actions and other executive branch actions can come to a screeching halt at midnight on January 19th if the new president doesn't support the final implementation of those actions. So FDA has organized its action plan into short and intermediate and long-term goals, and we know that it's those short-term goals that we need to put the pressure on them and applaud them when they do it to get those accomplished before January 20th, 2017. And then back to my analogy of hammers and nails, the FDA is only one way. So on the next slide, you see that the FDA can get us a lot. The FDA, the companies that need their product to be approved by the FDA have to pass FDA approval, and that is where we can get a lot. If FDA encourages them to do better on people of color, that will probably have results. And if FDA keeps publishing the drug snapshots that show people how many older adults, how many women, how many people of color, that will help us get results. But we do need more, and we do need a lot of things that the FDA really can't control. So we need broader public pressure on NIH, on the companies, on industry, and I think it's organized pressure from groups like Breast Cancer Action and the network and others that can get us to what we ultimately want to get to. And just want to say thanks for letting me speak with you today about this.
Thank you so much, Cindy, and thank you so much to Galen excuse me. I want to take a moment just to review a few resources that were mentioned in both Galen and Cindy's presentations. The first is the National Women's Health Network, just a wonderful resource for advocacy, and if you want to get involved in the work that they do, their website is on the screen. Also, I put Shanti's address up there as well, also another wonderful organization. They're Bay Area based here in San Francisco. There's also the FDA Snapshot if you want to look at those other 13 drugs that are currently available. That's the website there. Galen mentioned the breast cancer trials, and their website is up, and they match people with cancer trials in their area. There's also a National Cancer Institute Contact Center information line, and you can go to the website, and there's also a phone number. I also wanted to add a really great article that actually helped spark this webinar, which is the FDA Needs an Action Plan for More Inclusive Clinical Trials. It was written by Cindy and one of our board members, Susan Wood. It's a great read, and will help you give a little more depth, if you'd like it, on the FDA and the action plan. So I will also be sending these resources in a follow-up email if you haven't had a chance to madly write it all down. So we are going to open it up to your questions in a minute, so please continue to write your questions in the question bar. But before we do, I just want to talk a little bit more about how you can get involved with Breast Cancer Action. You can be a member. You can sign up for our news and action alert emails to keep up to date on the many issues that we work on. You can also join us on Facebook and Twitter to connect with others and help change the conversation about the breast cancer epidemic. You can also help others get involved. You can tell your friends, your coworkers, or family members about this webinar. And last, you can donate to support our educational and advocacy work. Because again, as I stated before we began, we really rely on your support to make our webinars and our work possible, and your individual support is so crucial. If you've been inspired today, you can make a donation of $25 or more so we can continue these webinars, and the website is up on the screen. I want to give a really big thank you to Galen and Cindy for their wonderful presentations today, and now I want to have time to answer any and all of your questions. So we have a few questions we'll start, and again, please continue to write in questions as you think of them. So the first one, or the first couple, are about the slides for this presentation. I just want to let everyone know that we record all of our webinars, and we make them available on our website as well as PDFs of the slides. So that should be up about a week following the last webinar. And you can, again, as I said, I will be sending a follow-up email, and it'll have information in there on how to access those. There's a question, I think this is for you, Galen. Someone says, what is the name of the article that discussed improving accrual to clinical research using effective communication with diverse patients?
Let's see, that's a good question. I'm not sure I have it handy in front of me, but I can find it and either have Saru send it out, or if you want to keep going to some other questions, I can see if I can find it and get back to you before we get off the webinar.
Great. We'll do that. So if you can't find it while we're talking, I do have the person's email, so we can connect with them.
Okay, great.
So there's another question that says, regarding inclusion of people of color, what is the, quote, right number proportional to the prevalence of the disease or the proportion of the population? What does that look like?
This is Cindy, and that is an ongoing conversation, and the FDA has also engaged in that conversation. It does seem reasonable if to use either of those benchmarks as a goal, and then explain that was the attempt. So proportional to the population, sometimes maybe that seems reasonable. Proportional to the prevalence of that particular condition, sometimes that seems reasonable. And sometimes when we've had a big advocacy impact on the design of the trial, I'm more familiar with this in situations where there's public funding of the trial. We argue for, and the trialists succeed in overrepresentation of women of color, that's just what I'm most familiar of. I'm thinking now of there's a natural history trial of menopause where women of color were overrepresented because of just the paucity of information, so sometimes you can even make that argument.
Great, thank you. There were a few questions that just wanted to hear a little bit more about if there are some innovative solutions that are being worked on to sort of address those larger systems and institutional barriers besides, Galen, the one you spoke about, the NCORP, if there were others that you're familiar with or that are being worked on.
So that's a really good question. I think that there are a lot of people working on these issues. I think there's been less focus on the systems issues than on patient-provider dynamics overall, and I think it would really benefit all of us if we could focus more on the systems issues. Of course, as most people, I'm sure, who are listening know, those are much harder to tackle because they involve issues of power and the healthcare system overall. One of the big issues is where clinical trials are available and where does that match up with where people of color seek care when they're diagnosed with cancer? And to some extent, that really does not match up, and that's what NCORP is trying to mitigate to some degree, is to match up where clinical trials get opened and where people of color seek care. But I think, to some degree, the increased access to care through the Affordable Care Act has some potential to help with this issue. And but yeah, unfortunately, I don't have a sort of easy answer or list of projects on this level.
Yeah.
This is Cindy. I'll just add, I completely agree with what Galen is saying about the sort of the lack of system responses, but one that could have an impact is the proponents of something called large, simple trials, that we collect a lot of information in clinical trials, particularly trials that are designed for FDA approval. But if we're out in the real world looking at how effective is something that maybe has been approved for one use and now is being considered for another, or certain kind of interventions, or the eventual mortality benefit of an intervention that was approved based on an earlier endpoint. Just asking regular old clinicians who are in the community to enroll someone with the promise of answering 3 questions a year, and providing 5 pieces of information to start with, can get information that is useful, and it's a lot easier to seek out and make it possible for the clinicians to participate who are seeing the true diversity of people receiving that kind of care.
Great.
I also just thought of another thing as Cindy was talking, which is that there is an effort that's ongoing here at UCSF in the Breast Care Center to move people through different kinds of treatments that are being tested much more quickly than they have in the past. So rather than signing up for a trial for one drug and having to stay in that trial whether that drug is working or not, it's a system, a different way of approaching clinical trials where it's a series of tests. So you try one thing, if it's not working, you move on to the next, and if that's not working, you move on to the next. So it is an attempt to change how clinical trials are run. Whether that has an impact on recruitment, I'm not sure, but it does mean that people won't stay in trials as long if it's clear that it's not working for them. So it would give more opportunities to try a treatment in different people potentially, and for a given individual to try more than one treatment.
Great, thank you both. So I actually am going to end our call today because we have hit 3 o'clock, and I want to respect everyone's time, and I want to thank everyone for their really thoughtful questions and comments. And if you have a question that wasn't answered today, you can follow up with us at info@bcaction.org. And again, please watch your email for a short survey where you can provide some feedback on this webinar. Thank you so much for attending, and thank you again to Cindy and Galen for their wonderful presentations.
You're welcome. Bye, everybody.
Bye-bye. Thanks.